Hello, and thank you for joining us. My name is Jenny Pagel-Guile, and I am the Executive Director of the National Pancreas Foundation. The National Pancreas Foundation provides hope for those suffering from all forms of pancreatic disease. We fund research, advocate for better services and access to care, and provide support and education for patients and caregivers alike. We've awarded over 5 million grants as an organization, and we endorse over 180 centers of excellence across the country. We additionally provide programs, education to medical providers, patients, and their caregivers, providing a rounded scope of education and support to our community. There are many ways that you can be involved in the Pancreas Foundation, as well as several resources available online and on demand. We have the animated patient that provides detailed information about the diagnosis as well as the pancreas itself. We co-sponsor Camp Hope with Rebecca's Wish, our first pediatric pancreatitis camp in the country, and we provide nutrition support through our cookbook services and online webinars. All of this information can be found on our website, as well as a listing of all of our active centers of excellence. Across the country, we have over 30 chapters. These are volunteers and individuals who provide support to each other. They also provide grassroots efforts at tabling at local health fairs, providing fundraising support and education. They also sit in on advocacy calls at the local and national level. We would love to have you join us if you are able, or you can start a chapter in your community. Reach out to our staff if you would like to receive more information. Again, we have a full calendar of events, virtual and in person, on our website. We have an assortment of galas across the country. We have patient education events coming up in person, as well as medical professional events. And again, all of our webinars are available on demand online. The best way to stay up to date is to subscribe to our monthly newsletter. We also are on a variety of social media, so make sure that you follow us and share with your community and peers. We would love to have you join us. Now I would like to introduce our next speaker. I would like to welcome Dr. Willingham. He is an internationally renowned endoscopist and a professor of medicine at Emory University. He received his Master of Public Health degree from Johns Hopkins University, and he attended the University of Maryland School of Medicine and completed residency at Baylor College of Medicine. He completed fellowship in gastroenterology at Massachusetts General Hospital, Harvard Medical School. He completed therapeutic endoscopy fellowship in the Joint Massachusetts General Hospital plus Brigham and Women's Hospital Harvard Medical School program. He is board certified in gastroenterology. Dr. Willingham is a core member of the Winship Cancer Institute at Emory University, the director of endoscopy at Emory University for Hospital, and the medical director for therapeutic endoscopy for Children's Healthcare of Atlanta. He is the associate division director for academic affairs for the Division of Digestive Diseases. He was named a fellow of the American Society of Gastrointestinal Endoscopy in 2016. He served as the president of the Georgia Gastroenterology and Endoscopic Society from 2014 to 2016 and remains on the board. He has published hundreds of peer-reviewed manuscripts, abstracts, and chapters. He serves as the medical director for Georgia for the National Pancreas Foundation. He has been the principal investigator for multiple clinical trials, and in 2021, he became the editor-in-chief for Video GIE, the official video journal of ASGE. He has received numerous awards for teaching, research, and patient care. He lives in Atlanta with his wife and 3 sons. Welcome, Dr. Willingham.
Hello, everyone. Thank you for tuning in. Thank you for your interest in this webinar. We're going to be talking about EUS guided ablation for pancreatic tumors. I'm very thankful to the National Pancreas Foundation for the invitation to present the webinar. Thank you to the institution. We're delighted, and we'll go ahead and get started. So the learning objectives for the webinar, we want to talk about the epidemiology of pancreatic cancer. We want to review the current state of the field of EUS guided approaches to pancreatic ablation. We're going to look at some of the published literature to date about EUS guided radiofrequency ablation, and we're going to conceptualize the future directions for these approaches for treating pancreatic tumors. So this is a surgical specimen. A friend of mine who's a surgeon removed this tumor. It looks pretty rough here, but believe it or not, these are actually the lucky patients. This is from a surgical series here that looked at early pancreatic cancer. This is stage 1. And as you see, this is the group of patients who did not undergo resection. And so the vast majority of patients, even with very early tumors, are not getting resected. So we actually looked at this and wanted to study what we call the treatment gap for patients who have localized pancreatic cancer in the United States. And I'll show that to you here. If we look first at the incidence of pancreatic cancer, these are for patients who have non-metastatic disease. And in the blue here, these are patients who have no nodal involvement and who have a tumor size less than 3 centimeters. And so you can see this data is from the SEER database, which is a large US cancer database, that the incidence of pancreatic cancer is increasing over time. And in fact, there was a 106% increase in the incidence of pancreatic cancer with a tumor size less than 3 centimeters with no nodes and no metastatic disease. We also know this is the survival for patients with pancreatic cancer. This is the group here who were resected, and these are patients who did not get resected. There is some selection bias. This group tends to be healthier patients who do not metastasize in the pre-op period. Nevertheless, the group who is resected has a much better survival over 5 years. This is the group, though, of patients that get resected, and unfortunately, the vast majority of patients, even with early stage pancreatic cancer, are not recommended for surgery, or surgery is contraindicated. This group is the group that for surgery, for whom surgery is recommended but not performed, and it's only this small group of patients who actually undergo surgery. So kind of putting this all together, we consider tumors resectable if they're stage 1A or 1B. However, only 49% of patients with stage 1A tumors and 28% of patients with stage 1B tumors are getting resected. So about 77% of patients with non-metastatic pancreatic cancer, no lymph node involvement, and a tumor size less than 3 centimeters do not receive surgical resection. The incidence of pancreatic cancer in this group is also increasing. And so there is this large unmet need for some local treatment option for the management of patients with pancreatic cancer. And so how might we do this? So this is what we call endoscopic ultrasound. So this is an endoscopic procedure. This is the endoscope, and it's passed down into the stomach. This is the ultrasound transducer here on the end of the scope, and we can place that right next to the pancreas and the pancreatic tumor. And we can use this ultrasound guidance to do a biopsy and get cells from the tumor, and this is the way the majority of pancreatic tumors are diagnosed. So the great sensitivity of this approach has led to the desire of many to be able to offer some treatment options using this same paradigm. There have been many attempts over time to develop local treatment options. This is a probe-based device, so a needle is placed into the pancreas, and then this probe is passed through the needle and energy is delivered. This is not really in use anymore. There was a microwave ablation device that was seeking approval. I believe it is not going ahead. And then there was a device that used something called hybrid cryotherm. to ablate tumors, and this has been pulled off the market. However, there is a radiofrequency ablation device now that can be used to ablate pancreatic tumors. And then there are some newer things that are coming. So there's a technology that uses particles with alpha radiation, which can be introduced into a tumor. And there's something called irreversible electroporation that has been used for tumors for a while, and it looks like an EUS guided approach is coming. So there are technologies which are now able to ablate tumors in the pancreas with EUS guidance. That means no surgery and no punctures through the skin. So the questions that come up, why might we consider doing local ablation for pancreatic tumors? And these are some of the things that you might think of. So perhaps it's going to give patients peace of mind, knowing that their tumor is being treated. Perhaps we can improve survival or disease-free survival if we ablate the primary tumor. Maybe we will improve symptoms. So can we decrease the likelihood that a tumor will obstruct the bowel or obstruct the flow from the bile duct? And then there is something called an abscopal effect, and this has been seen in radiation therapy, where radiation applied to the primary tumor leads to reduction in the sites of metastatic disease. And the thought is that the destruction of the tumor leads to sensitization, and the body recognizes the tumor particles and then can attack the tumor at the distant sites that were not radiated and cause regression there as well. And so there is a hope that perhaps treating tumors with radiofrequency ablation might induce the same abscopal effect. Here is a paper that we published in the journal Video GIE. This was a patient with an unresectable pancreatic neuroendocrine tumor who underwent the novel microwave ablation with successful treatment of this tumor. As I mentioned, probably the technology that is furthest along right now is radiofrequency ablation. This is a paper that we published reviewing the current state and summarizing all of the data so far on radiofrequency ablation. And this is the list of studies that have been published. As you'll see, most of them outside the US. And as you can see, most of these are small studies. You can also see that this is the technical success rate, meaning were they able to identify the tumor, place the ablation device into the tumor, and deliver the energy. And then this is the clinical success rate, which is often defined by a radiologic outcome. This is the sort of state or the publications to date on EUS guided radiofrequency ablation. If I kind of summarize these, it is an emerging technology. There are multiple small studies. These studies are uncontrolled, and so they're more proof of concept and demonstrate procedural safety. There does seem to be a very low adverse event rate, so it seems to be very safe and very well tolerated. The technical success rate is very high, meaning the ablation device can be introduced into the tumor and the energy delivered. The follow-up has been short, so we don't have long-term follow-up data. And the impact on survival, disease-free survival, quality of life, propensity to metastasize is not clear. So I just wanted to share a patient that we treated. This was one of the first patients that we treated a number of years ago. He was actually 90 years old, and he had an insulinoma, which is an insulin-producing tumor. He had a few other medical issues, and he was following with oncology. And he had this neuroendocrine tumor in the tail of his pancreas, and he had had this tumor for about 10 years. He was having repeated recurrent hypoglycemic episodes. So he would be symptomatic with very low blood sugar multiple times a day. And he actually had to wake up every couple of hours at night to eat to prevent his blood sugar from dropping. And he recently had to stop riding a bike. Yes, he was riding a bike at 90, but recently had to stop. His C-peptide and insulin levels were elevated, and a glucose monitoring study had been performed, and his glucose was only in the target range for about a quarter of the time. It was never high. It was low 58% of the time and very low 17% of the time. So he had a very significant hypoglycemia. So he saw one of our surgeons here, and this is from her note. And she said, I had a long discussion with him and his daughter. We discussed the quality of life issues he was having with his insulinoma and the risks and benefits of surgery. And she said, I'd been very honest with them about the perils of operating on a 90-year-old patient. And although he appears much younger than his stated age, I have concerns if he has a complication such as a leak that he may very quickly appear greater than his stated age. And that being said, the operation would be a distal pancreatectomy and splenectomy due to the location of the tumor. And this is a scan of his, and this is the tumor. This is the pancreas here, and this is the tumor at the tip of the tail near the spleen. So this is the ablation device that we use. It's EUS guided. It is coded. So there is a sheath here that prevents the energy from passing through this portion. And then this is what we call the ablation zone. And so this is the zone that we try and place into the tumor and deliver the radiofrequency imaging or energy. This is from a paper we published describing the technique, and the greater the time that you deliver the energy, the larger the ablation field will be. And there are different sizes, and so we can place different length catheters into the tumor to get different ablation zones. This is a video that shows what the ablation looks like. This is endoscopic ultrasound, and this dark area here is actually the tumor in the pancreas. And we will label that. This is the ablation device being introduced under EUS guidance. And we're passing the ablation device, and you can see we've passed it now into the tumor. And then we will deliver the energy, which appears to us on EUS as this sort of bright bubbling effect. You can see it probably a little better here. So the energy is being delivered, and then there's this bubbling area as the tumor is ablated. And so this is the post-ablation appearance. This, for comparison purposes, this is a patient with a non-functioning neuroendocrine tumor here in the pancreas. This is the tumor here, which you can see in a background of otherwise normal pancreas. Again, we've introduced the ablation device into the tumor, and this is the bubbling effect as the energy is delivered and as the tumor is ablated. We typically will look around some more after this ablation has been performed. We want to make sure that we have treated all the tumor cells. So we have looked around a little bit, and there's a portion of the tumor over here that looks like still needs to be ablated. And so we'll redirect the device and ablate the lateral edge of the tumor. This is a patient with pancreatic adenocarcinoma. You can see this is a much larger tumor. This is in the head of the pancreas. It has this irregular border. It's abutting the portal vein, so much harder to treat. This is a stent in the bile duct here. The tumor was obstructing the bile duct. And so we're treating this tumor here and pulling back and trying to get ablation of the majority of the tumor here. This tumor is much larger and requires more passes and more ablations to deliver energy to the entire tumor. Here we've rotated again and repositioned the trocar and are delivering more energy into the tumor, trying to get rid of as much of the tumor as possible. So this is a case that we discuss, and I've asked my fellows. This is a patient of mine, and he has a very tiny tumor in the head of the pancreas. It's about 6.5 by 4.5 millimeters, so very tiny. This tumor would respond very well to ablation. It's also very small and may not cause him any problems over time. This is a non-functional neuroendocrine tumor, so he's really not symptomatic from this. And so one of the questions that we are asking is, should this tumor be ablated? And I'm not sure we really know the answer to that question yet, but it serves as a good discussion. Should this patient go on to an ablation? Here is a caveat. This is a patient who was referred for ablation of a pancreatic tumor, and we got a scan right before his clinic visit where we were going to discuss the ablation, and unfortunately the scan showed metastatic cancer in the liver, and so it's very important to be sure you know the exact stage before we embark on radiofrequency or other modality ablation. So back to our 90-year-old patient with the insulinoma. This is on the day of his ablation, and you can see this is the normal range for blood glucose, and you can see that he is bottoming out his blood sugar repeatedly in the pre-procedure period of time. This is the radiofrequency ablation, which was performed here. And then this is his blood sugar throughout the remainder of his hospital stay. And you can see he actually never dropped below the lower end of normal for blood sugar immediately following the ablation. He did have some elevated readings, and we do see this sometimes. We believe patients have compensated for this inappropriate insulin secretion, and it may unmask diabetes, underlying diabetes, or it may take some time to reset to a normal blood glucose range. This is the insulin and C-peptide levels. So this is his insulin level, which was high pre-procedure and returned to normal post-op day 1, post-op day 2. And similarly, this is his C-peptide level, which was dropped to the normal range following the ablation. This was his inpatient stay, and he actually felt great and never had any pain or discomfort over his hospital stay. And it was incredibly successful. So this is the note from his follow-up with surgery, and they commented we had recommended surgery to remove the tumor. However, he declined surgery. He underwent EUS with radiofrequency ablation. He reports immediate resolution of hypoglycemic episodes. His wife brought in a 24-hour blood sugar log, and his glucose never dropped below 71. They had prescribed this Afinitor daily. However, he never started it, and so we're going to hold and proceed with surveillance. And this was a message that his wife sent me. This is a follow-up of our phone conversation. I did several finger sticks to compare with the Libre readings. The Libre readings are usually lower than a finger stick. And in 24 hours, his levels by finger stick never dipped below 71. We've been monitoring how his levels dip postprandially. He leveled out at 90 at 11 o'clock. I did a finger stick at 2 a.m. and it was 77. It's a miracle. Thanks. So he had really a remarkable outcome. This is another patient that we saw. She was 66, had an extensive past medical history and very problematic hypoglycemia. She had actually initially presented in 2010 with hypoglycemia, and her MRI had shown a lesion in the head of the pancreas. So she had actually been taken to surgery, and they could not locate the lesion intraoperatively, and they ended up doing a distal pancreatectomy and a splenectomy, but it was unsuccessful at locating the tumor, and she continued to have hypoglycemia after the surgery. She was also treated with diazoxide, which she stopped due to poor efficacy and taste problems. They tried octreotide injections, which didn't work. And eventually she was told she would require a completion pancreatectomy for persistent symptoms and failed medical therapy. However, this would have resulted in severe brittle diabetes and total exocrine insufficiency, and she did not want to undergo this. She had actually developed knee problems related to extensive weight gain, having to eat constantly to keep her blood sugar up. And she was up to 262 pounds when we saw her. So she was referred and had a dotatate scan, which showed a lesion in the uncinate process. She was evaluated by endocrine surgery here, and they decided against surgery due to all the risks of taking the pancreas out entirely. And so they referred her over to see us, and she underwent the EUS guided radiofrequency ablation for the mass lesion. And then this is from her note back with endocrinology. And they noted that she had no low blood glucose. She was checking periodically, and it was usually around 100. Her hemoglobin A1C was in the normal range. She had been able to get on a step peddler and was doing 30 minutes daily and had joined a gym, and she had lost 17 pounds over the past year. And then she saw my PA in the clinic, and this was the note. She's had remarkable improvements since the ablation. She no longer has these episodes of hypoglycemia. She's no longer having to eat constantly and has had no hypoglycemic symptoms. She's been able to exercise 3 or 4 times a week, and she's been able to lose 80 pounds since the ablation. And her blood sugars have all ranged from 100 to 120. And she, was told to contact us if the hypoglycemia were to return, and to continue to follow up with endocrinology. So she was remarkably improved and had a terrific outcome. If you're interested in this area, you can look at our publication. This is a series of patients that we treated with insulinomas, and their treatment with radiofrequency ablation. So, kind of in summary, even though there's not a ton of data, we believe that this is an excellent treatment for functional neuroendocrine tumors such as insulinomas. These patients are symptomatic. The potential for metastatic disease is low. You may not need to get a 100% ablation to resolve their symptoms. And so this is an excellent group for consideration for ablation. The non-functional neuroendocrine tumors, this is sort of less clear. These patients are asymptomatic. The metastatic potential may be variable, and it's less clear sort of what are the benefits of ablating the tumor. Will we be presenting some complication down the road is something that we'll have to evaluate over time. And then I think the least clear group is the patient with adenocarcinoma. These are symptomatic. There's a very high metastatic potential, and we don't yet know the benefit of incomplete ablation for adenocarcinoma. So we've said, this is prime time and daytime and subscription only. So that's my presentation on EUS guided ablation for pancreatic tumors. I hope this was helpful. If you are a patient and you have a tumor, particularly a functional neuroendocrine tumor, we'd be happy to see you and evaluate that for an ablation. But thank you again to the National Pancreas Foundation for the recent redesignation as a Center of Excellence for Emory, and for the invitation to do the webinar today.